The chapter now is devoted to cardiothoracic surgery. We're going to begin with congenital heart problems. A 6-month-old baby has occasional stridor and episodes of respiratory distress with crowing respiration, during which he assumes a hyperextended position. The family has also noted mild difficulty in swallowing. If you have a question on the exam where a baby makes noise when he breathes, if that question says the noise is when the air is going out, the child has asthma. If the noise is when the air is going in, the child has tracheomalacia. But if there is noise with breathing as well as trouble swallowing, then what you have is a vascular ring. If you remember from embryology, at one time in development, we have 2 aortic arches, one of which eventually disappears and becomes something else. This is a baby who was born with the 2 aortic arches still in place. There is essentially a vascular ring, as the name implies. There is a circle of blood vessels, and the trachea and the esophagus go right through the center of that circle, and that circle of vessels is constricting, impinging upon both trachea and esophagus. A barium swallow is done in a baby like this. It shows extrinsic compression, and a bronchoscopy is also done, which shows a segmental tracheal compression and rules out tracheomalacia. And the surgical repair divides the smaller of the 2 aortic arches. Vignette number 2 says a patient known to have a congenital heart defect with a hemodynamically non-significant shunt requires extensive dental work. It's a reminder to us that any morphological abnormality of the heart needs protection against subacute bacterial endocarditis if that patient is going to be exposed to a shower of bacteria in the blood. And with that, we move to vignette number 3, because now we're going to review the congenital anomalies in which there is a hole between chambers of the heart and therefore a shunt. And there are 2 groups here. The group where the shunt is from left to right and therefore the baby is not cyanotic, and the group where the shunt is from right to left and therefore the baby is cyanotic. So we're going to begin with a non-cyanotic. We're going to review 3 different conditions. Vignette number 3. During a school physical exam, a 12-year-old girl is found to have a heart murmur. She is referred for further evaluation. An alert cardiology fellow recognizes that she indeed has a pulmonary flow systolic murmur, but he also notices that she has a fixed split-second heart sound. A history of frequent colds and respiratory infections is elicited. This is a pretty classical description for an atrial septal defect. You should not be surprised that in the presence of an atrial septal defect, a child might be able to grow to the age of 12, because an atrial septal defect doesn't have an enormous flow through that shunt and is not damaging right away. Eventually, though, the murmur is heard, the child is evaluated, and my friends in the field tell me that that fixed split-second heart sound is virtually diagnostic of an atrial septal defect. And then once we are alerted to the presence of the anomaly and questions are asked from the family says, oh yes, doctor, this little girl has always been having cold, she's sniffling all the time, and that is a sign of the congested lung. Because you see, these child doesn't have a left to right shunt. They have a murmur, and they have excessive pulmonary circulation, which may be simply a radiological finding, increased pulmonary vascular markings. It may be, like in this case, a history of a lot of colds and upper respiratory infections. It may be, in some cases, actually overt failure very early in life. And now I have the good news for you. because the workup for this particular vignette and many of those that follow is the same. When we are confronted with a morphological abnormality of the heart, the first thing we do is an echocardiogram. In most of the times, it's the only workup we need to do. It's very rare nowadays to have to do a cardiac catheterization to gain enough information to know what's wrong with the heart. And so after this child has the echocardiogram, we then have to close the defect. This can be done with open surgery or by means of cardiac catheterization. Now we move to vignette 4. A 3-month-old boy is hospitalized for failure to thrive. Let me translate that for you. Failure to thrive is a commonly used expression that indicates a baby is not growing at the rate the baby should. And often it signifies not a problem with the stomach or the GI tract, but a problem with the heart. The baby is short of breath. And because the baby is short of breath, the time the baby spends at the mother's breast feeding, a lot of that time the child is coming up for air. It's coming up to breathe rather than drinking the milk. And so they do not grow. He has a loud pansystolic heart murmur, best heard at the left sternal border. Chest X-ray shows increased pulmonary vascular markers. This is a ventricular septal defect. You can see that this one led to problems considerably earlier than the previous one because you have a higher flow through a ventricular septal defect. The typical ventricular septal defect is right under the mitral and tricuspid valves in the membranous part of the septum. The chest X-ray shows the increased pulmonary vascular markings, and our next move, you already know what it is, echocardiogram, and then surgical closure. But I have to alert you to the existence of another type of ventricular septal defect that has a different evolution and meaning. Because of a heart murmur, an otherwise asymptomatic 3-month-old baby is diagnosed with a small restrictive ventricular septal defect located low in the muscular septum. This particular variant of ventricular septal defect has a good chance to close by itself in the first 2 or 3 years of life. And so this child needs antibiotic prophylaxis should he be exposed to bacterial showers because of the issue of bacterial endocarditis. But he can be safely observed. We repeat from time to time the echocardiogram until this thing closes. And now we move to the third of the conditions that we were talking about. This is an even younger patient now, a 3-day-old premature baby, has trouble feeding and pulmonary congestion. Physical examination shows bounding peripheral pulses and a continuous machinery-like heart murmur. Shortly thereafter, the baby goes into overt heart failure. This is a patent ductus. Echocardiogram will confirm the diagnosis, and in this particular case, surgical closure is needed. In premature infants, we can treat the patent ductus with indomethacin, but indomethacin takes a few days to achieve the desired result, and if the baby is already in overt heart failure, you don't have the time to wait for that. So the answer in this vignette is do an echocardiogram and a surgical closure. But in the next vignette, you'll see the example where the indomethacin can do the magic. Vignette 7. A premature baby girl has mild pulmonary congestion, signs of increased pulmonary blood flow on X-ray, a wide pulse pressure, and a precordial machinery-like murmur. She is not in congestive failure. A perfect candidate for medical treatment with indomethacin. Let me alert you to the key words that we've already read here a couple of times. That murmur of the patent doctors is always described as a machinery-like murmur. So the instant you read on an exam question, machinery-like murmur, you know that's a patent doctors. Now we're going to move to the congenital anomalies, where the shunt is from right to left, and therefore the baby is cyanotic. There are 5 of those diseases, all of which begin with the letter T. The tetralogy of Fallot, transposition of the great vessels, tricuspid atresia, truncus arteriosus, and total anomalous pulmonary venous connection. But we're not going to review all 5. 3 of those are pretty rare. We'll review only the 2 most common ones, and the most common one is tetralogy. Let me start with that one. A 6-year-old boy is brought to the United States by his new adoptive parents from an orphanage in Eastern Europe. The boy is small for his age and has a bluish hue in the lips and tips of his fingers. He has clubbing and spells of cyanosis relieved with squatting. He has a systolic ejection murmur in the left third intercostal space. Chest X-ray shows a small heart and diminished pulmonary vascular markings. EKG shows right ventricular hypertrophy. Now this is the tetralogy of Fallot. You have the whole picture here. You know the next move is an echocardiogram followed by surgical repair. Now let me use the same vignette to alert you to the next most common of the cyanotic anomalies. The next most common is the transposition of the great vessels, also a cyanotic condition. But transposition is a real problem, and a baby would not survive with transposition up to the age of 6 years untreated. So when you read a question on the exam where a baby is cyanotic, but that baby is already 6 years old, not a baby anymore, but a boy, that's tetralogy. If you have a question on the exam where a baby is just a few days old, very blue, very cyanotic, and in deep trouble, chances are it is transposition. You know what to ask for anyway. It would be an echocardiogram. Let's review again a little bit of the congenital anomalies by means of pictures that we have for you before we move to acquired heart disease. Here is a schematic representation of a ventricular septal defect. I might add, this is kind of a, imaginary thing because it's a picture that shows you all the chambers and things. The typical ventricular septal defect is a little higher than this diagram shows. It's right underneath the tricuspid and the mitral valve. But of course, it's hard to depict that in a drawing like this. Here is a picture of a baby, an X-ray of a baby with ventricular septal defect before closure, and there are the increased pulmonary vascular markings. That is what you're looking at. And then after the closure, the increased pulmonary vascular markings have ameliorated. Here is a schematic representation of where the patent ductus occurs, obviously between the aorta and the pulmonary. Here is a patient with that condition, and here is now a schematic representation of what's wrong in the tetralogy of Fallot. In this particular drawing, they have included a depiction of the palliative shunt that used to be done before we could correct this. It was called the Blalock-Towson shunt. Nowadays, this can be repaired primarily when the diagnosis is made. There is another schematic representation of the various components of the tetralogy of Fallot. And here is a child who has a disease. I don't know how good you are at little details, but you might realize when you look there that the pulmonary vascular markings, you don't see them, because this is the very opposite situation to the one that we had reviewed earlier, When there is a left to right shunt, there are increased pulmonary vascular markings. When there is a right to left shunt, there are decreased pulmonary vascular markings. And that's the end of the congenital heart problems.